Yes, we are live.
Okay, so good evening, everybody. Welcome again to this weekly CME program done through the Orthopedic Research and Education Foundation on the platform of Ortho TV. I think today we are fortunate to have Dr. Taral Nagda with us. I think I don't need to introduce him. All of you anywhere across India would know him. And he's going to talk to us about this neonatal septic arthritis and sequelae. I think this is a very important area. Unfortunately, almost every week we see one infant who unfortunately hasn't been diagnosed on time, and a lot of them have been in the neonatal intensive care unit, etc. And by the time they come to you, the hip is already beyond full salvage. So you're ending up doing drainage, and debridements, but that hip is never going to be perfectly normal. So I think Taral's going to tell us about how you avoid these problems, and when you do have these problems, how you deal with them. So Taral, over to you.
Okay, so John, thanks for that introduction. Of course, we have to prevent the sequelae of septic arthritis of the hip. And the prevention is by the prompt treatment, early recognition and prompt treatment, and which is nothing short of draining the hip and giving appropriate antibiotic. So, of course, that's a topic for another sort of talk. But today what we are going to discuss is the sequelae. So once you have a damage to the hip joint, which can occur in many ways. It can be damage to the articular cartilage, it can be damage to the growth plate, or can be damage to the vascularity, which give rise to a vascular necrosis. Or a combination of all of these can give rise to sequelae of septic arthritis of the hip joint. And these are some stories from the past. So past is gives you the experience, and that's the best teacher. And this is a PG teaching program. And before we come to the stories, little basics about the classifications and what they signify, I'll come to. So this is Dr. Choi from Korea, and he sort of and Dr. Bowen laid down this classification, which actually came from USA, from DuPont Institute. Choi was a fellow at that time, and this classification bears his name, but it was Bowen's sort of a philosophy which is reflected in this classification. And it's a very simple classification which divides sequelae into 4 types. Type 1 has either no residual deformity or has mild coxa magna. Okay, so hardly any damage is done to the hip joint, and coxa magna is because of increased vascularity. So no damage is done if it's type 1. So you are lucky if it's type 1. Type 2 is the one where there is involvement of the neck, and it can give rise to coxa brava if the neck is short, or if there is medial or lateral insult, it can give rise to coxa vara or coxa valga, and this is basically because of the fascial arrest. Now, type 3 is where the neck is damaged, and if the neck is damaged, it can slip. The capital femoral epiphysis can slip, and that is type 3A. And if neck is completely damaged, it gives rise to pseudoarthrosis with the presence of intact head. So that is type 3B. So type 3 is damage to the neck, and type 4 where head is absent. So it can be partially absent with a small beak of the neck present, then it's 4A, or it can be completely destroyed, what we call as Tom Smith arthritis, that is type 4B. So that is Choi's classification from USA. Dr. Jory, who's been teacher to many of us, he did his research on this topic when he was attending at Children's Orthopedic Hospital, which has now become SRCC Children's Hospital, where I am coordinating the pediatric orthopedic department. So a legacy from that institute, and this classification is from Dr. Jory's compilation of work from that institution, and he divided these into type 1 to 5, groups 1 to 5, which are little difficult to remember, but group 1 is where small neck is present, and that corresponds to Choi's type 4A. So head is not complete, head is completely destroyed, but there is some neck present which gives rise to stability. Group 2 is where head and neck are completely destroyed. It's an unstable hip, but the good range of movement is present. It's a pain-free hip, so it is choice type 4B. Joris type 4, type 4 is where there is coxa vara or coxa valga, and that is choice type 2A. Joris group 5 is where pseudarthrosis of neck is present, so that is choice type 3B. Now you have Joris group 3A and 3B, where the hip can be either dislocated or subluxated, and they have no representation in choice classification. So these are two additional types which are not seen in choice classification. And choice 1A, 1B, which is normal hip and coxa magna, 2B, which have coxa vara or valga, and 3A, which has essentially slip. They are not represented in Joris classification. So someone needs to work on this and combine choice classification and Joris classification. Probably that would be an all-inclusive classification. So everything put together would mean a lot of things. But Joris classification, you can group into two types finally. Group 1 and 4 are where the hip is stable, but range of movement is restricted. 2, 3, and 5 are ones where hip is unstable, there may be shortening, but good range of movement is present, and patients are generally painless with Trendelenburg gait being present. Okay? So these are roughly, how you can classify Joris type. So whether it's choice classification or Joris classification, there are 4 basic problems in septic sequelae of the hip joint. The first problem is stability, and stability is absent if head is absent or there is pseudarthrosis at the neck. So any of these issues can give rise to instability. If hip is dislocated or subluxated, again there will be instability. The second issue is shortening. The shortening can occur because of dislocation or coxa vara, which is supratrochanteric shortening, or shortening can come because the growth plate is damaged, and that gives rise to resultant shortening of the lower limb. And all of us know that most of the femoral length occurs at the lower end of femur, so damage to upper end of femur can give rise to maximum 25 to 30% of shortening and not more than that. There can be deformity, and deformity can be because of added soft tissue contracture, because of femoral head deformity or deformity of the neck. And there is disability finally, which can result from problems of stability, shortening, deformity, pain, limb, everything adding together to functional disability. So that's how I would analyze, a case of sequelae of septic arthritis of hip. So let's see some of the cases here. So this was the child who had septic arthritis of hip in 2006. And these were the x-rays at that time. The child was treated with aspiration, drainage, and antibiotics. And the question here to the treating physician was that femoral head is present here, but is the femoral head present here or no? So when you don't see a femoral head, it doesn't mean the femoral head is absent. And there are few cues you can take to know whether femoral head is present or no. One of the clues is presence of triradate cartilage. So if triradate cartilage is wide, it means that probably there is something present in the acetabulum in form of small or large head or a remnant of the head. And in these cases, one should not hurry up to do an investigations. You can do an ultrasound, but it's difficult to interpret. But many times you can do an MR, and this MRI clearly shows that femoral head is present. It is not seen because there is no capital femoral epiphysis, but femoral head is present. What it also shows is probably there was also septic arthritis of hip on the other side, which is not picked up on the x-rays. Okay, so MRI does help, and when you do MRI, do T1 weighted image, T2 weighted image, and also you should do fat suppression image because that shows cartilage very well. And because femoral head was present, we just decided to wait and watch. And as this child grew, you can see now, you can see a small spicle of femoral head, which is seen now here. And, then your speculation was correct that femoral head is present. And when the femoral head is present, what you're going to do is just encourage range of movement and keep a closer watch on the child. And as you take repeat x-rays, you can see now femoral head is seen. But what happens at longer follow-up? At longer follow-up, you see that femoral head is present, but probably there is coxa magna, coxa valga. And the question is, what type of sequelae is this? So probably, if you go by choice classification, probably it is combination of 1B and 2B, that may be coxa valga and coxa magna. And this femoral head probably needs containment as it is subluxated. Now, an issue is what is happening here. What kind of problem is here? And whenever you see a head like this, one more thing you should always do is take an X-ray in abduction and internal rotation. So we took X-ray in abduction and internal rotation, and suddenly the whole picture changes. You notice that the Chenton's line is restored now. The femoral head is contained, and in abduction, it looks very good. So what we do now for this patient is, this patient probably requires a varus and derotation osteotomy to contain it. And one thing we should realize is this is basically a growth problem. If the femoral growth plate is affected on the medial side, it will give rise to coxa valga. If it's affected, coxa vara, if it's affected on the lateral side, it will give rise to coxa valga. So this is known to all of us. But one thing which many of us don't realize is that there can be anteversion or retroversion depending on growth plate affection. So if the femoral head physis is affected anteriorly, this will give rise to excessive anteversion and subluxation of the head anteriorly, as happened in this case. If the femoral physis is affected posteriorly, it will give rise to retroversion. And when there is retroversion, these are the children who walk with outgoing gait. And what corrects these conditions is a derotation osteotomy. So it's very important that we are aware of this condition and do a CT scan or X-ray in different rotations to make sure that there is no rotational problem in sort of these subtle abnormalities or sequelae following septic arthritis of the hip. And what we were planning for this child is a varus osteotomy and a derotation osteotomy. Unfortunately, because of COVID, we couldn't perform it, and probably this vacation we'll be doing this procedure. So along with that, we also have to do trochanteric epiphysodesis because we want to prevent a lurch in that child. So this is a very simple sequelae which was picked up at long term. What we've learned from this case is that we must follow children with septic hip sequelae because some of the sequelae can come up late. Okay. And second thing what we have learned is if the hip seems to be subluxated, always take X-ray in abduction internal rotation because many of these can be also rotational problems. Okay, so let's come to a second case now. So this is a child who had multifocal septic arthritis, was treated with incision at drainage and sort of developed angular deformities. So when the child was 4 weeks old, this was the picture. And you can see as the child is growing, again a similar problem, the capital femoral epiphysis is not seen on the left side. And as you follow this child, the capital femoral epiphysis appears. But what you see is the neck shaft angle is not appropriate here. And is that a concern? You also see that there is missing physis, lower end of femur, and then affection of the upper end of the tibia on the left side. So lots of problem this child has. And naturally the attention here was on the knee. And this child was treated with osteotomy of lower femur on the right side and upper tibia on the left side. And hip was sort of observed. And if you see over a period of time, what is happening here is because of the physeal affection of the inferior physis, there is progressive coxa vara. Okay, so how do we treat this child? Now, this child should have been treated in 2009 with a valgus osteotomy. And one should also remember that when you do a valgus osteotomy, the acetabular index is not proper. And this child, in addition to doing a valgus osteotomy, will also require acetabuloplasty because otherwise the hip will become unstable. So this child, did not agree to surgery, the parents. And when they came in 2013, you can see that how the neck shortens and, the deformity progresses, the trochanter overrides. And if you don't treat in time, these are the problems which will continue to, progress. They are not going to be continued to solve on their own. And so this becomes classically choice type 2B. And the solution here is very simple. You have to get the hip in maximum adduction and take an X-ray. So this is the hip you want. And what you do is in this position, you pass a central guide wire and then pass a Richards at 130 degrees. So you get 130 neck shaft angle and translate the distal femur and correct the angulation. So it is angulation translation osteotomy, which gives you additional neck length. And then finally you transfer the trochanter, pull down the trochanter so that the abductor lurch will go down. So this is the surgery which was done at that time. And then subsequently we also did a triple innominate osteotomy for this child, so that the roof of the femoral head, which is the acetabular roof, was also made horizontal, and the complete reconstruction was done. So what we have sort of learned from this case is that Coxa-Vara is a known complication of sequelae of septic arthritis of the hip. You have to detect it early, and earlier you treat, the difficulty of the surgery will be less. In this case, just correcting the angle is not enough. You also have to build up the neck, do a neck lengthening as in the planning of the surgery, and many of the times you will also have to do trochanteric transfer. Some of the patients where acetabulum is not adequate, you may have to end up doing an acetabular procedure such as Degas or triple innominate osteotomy for these patients. Okay, so we come to an additional case. This is by Sandeep Patwardhan. So this is severe Coxa-Vara with version issues, and this was type 3A, which resulted from the slip. Okay, and this patient Sandeep treated early by doing valgus osteotomy with a fixator, and in another 2 years, again there was a recurrence of varus, and this patient required recurrent surgery. So Coxa-Vara, which follows septic arthritis of hip, they require recurrent surgeries, and in many of these patients, trochanteric sort of osteotomy or trochanteric transfer is required in addition to just doing a femoral osteotomy. So this is a child who has again come with sequelae of septic arthritis of the hip, and what is sort of very much noticeable from this X-ray is that this child has shortening of femur, but what is not noticeable from the X-ray that he also has pseudarthrosis of the neck. He has Trendelenburg's test positive, telescoping positive, and there is frank mobility at the femoral neck. The femoral neck is short, and there is a pseudoarthrosis. So this becomes choice type 3B, and it also becomes Jory's group 5, which is an unstable neck. And the treatment for this is abduction osteotomy and osteosynthesis of the femoral neck. So both done at the same time. And this child did well, healed well, walked well, had good range of movements. But it's very important to have long-term sort of a follow-up of this child. And what happens to this child when he becomes a 12-year-old child? Suddenly a good result turns into a mediocre result here, because he has pain, he has subluxation, the femoral head has coxa magnum, but acetabulum is not growing, so there is a problem on acetabular side as well. And at this stage he has now progressive subluxation, poor acetabular index, Shenton's line which is not getting maintained, and child having restricted range of movement. Almost half the femoral head is subluxated. So what seemed like initial good sort of a result, as you follow up these children, you realize your own fallacies, deficiencies, and the magic of the natural history of a disease. And in this child, again, what we had to do was acetabular surgery, triple innominate osteotomy to sort of cover the femoral head. And subsequently, we also have done lengthening of the femur for this child, and he is quite functional. So this is a child, you can see that it's the sequelae of septic arthritis of hip, and femoral head is completely absent. There is just a small remnant present, so this becomes type 4A of choice, and Jory's type 1, group 1. And this was the child which was treated by Elizarov hip reconstruction. So that's a procedure where you do a valgus osteotomy of the proximal femur, and this is basically done to support the femur and get the trochanter down to reduce the lurch. And at the same time, you do lengthening at lower femur, and you provide varus at lower femur to get the mechanical axis right. So it requires a very detailed planning. It's angulation, valgus osteotomy and proximal femur, and varus osteotomy and lengthening at distal femur, if you have to describe in one line. And this child in process of lengthening, you can see the medial translation, the varus which is done distally, and this was done with a hybrid fixator. You can see there is Elizarov fixator lower down for lengthening and a monolateral frame proximally, so that the child can tolerate this, can sleep, can sit and do activities. And you can see the child walking with the frame. And at end of this, we could achieve equal lengths for this child. So, did little over lengthening, because we knew that as the child grows, the length will be short. We achieved typical beach chair position. So this is the beach chair position of proximal femur, which gives now stability to the hip, and got a good amount of lengthening. And at end of this procedure, you can see that the child was equal in length, had good range of movement, was able to sit cross-legged, and was able to walk without any limp. In fact, it was very difficult for people who didn't know what he had, was to see which lower limb was actually involved. So such gratifying results can be obtained by Elizarov hip reconstruction, where head and neck both are absent. Many times you have difficult situation. This is a case from Dr. Premal Naik, where both femoral head were absent on X-rays. But when you do an arthrogram, you notice that head is present, but one of the hip is subluxated. And this was Johari's classification 3B, subluxated hip. Choi doesn't have an equivalent for this classification, and this was treated simply by doing varus osteotomy. And this patient eventually, on long follow-up, has done very well. So, in short, what I want to suggest and say that sequelae of septic arthritis of hip is a big spectrum. It's very important to prevent sequelae by early detection and prompt management by decompressing the joint and with antibiotic treatment. The management, of course, depends on the classification, but most importantly, it depends on the symptoms, structure, and age of the child. And the procedures which we can do for reconstruction are relocation if the hip is subluxated or dislocated, reorientation with osteotomies, either femoral osteotomies or acetabular procedures, or femoral and acetabular procedures, varus and valgus, head reshaping procedures, femoral reshaping procedures, acetabular reshaping procedures, and lastly, limb lengthening and tissue regeneration with Elizarov's apparatus. So it's a big menu we have, and depending on what is the sequelae, we have to, do the treatment. So, with this, I've completed the overview of sequelae of septic arthritis of hip in children. What we have learned here are two important classifications. One is Choi's classification and Johari's classification. We also learned that, there are four groups of symptoms: shortening, deformity, restriction of range of movement, instability, which together give rise to disability. And then we had these 5 groups of cases, and we learned how to manage this different group of cases, starting from observation and supervised neglect to femoral osteotomies, to open reduction of femoral head, to acetabular procedures, and Elizarov's hip reconstruction. So I hope if you have a case in the exam, which is a post-septic hip sequelae, I'm sure it will fall into one of these cases. And if you have attended this talk on Ortho TV, it will definitely allow you to become more confident while answering to your examiners as to what should be the management of these patients. So, John, I finished.
Thanks. That was very precise and to the point. So I'm sure there'll be a lot of questions from the postgraduate students, the DNB students. So we'll give them a chance first, and then we'll have some discussions along the way. Okay. So questions?
Yeah, Gautam.
Yes, sir. Good evening, sir. First question is, sir, timing of intervention is defined. Any timing of intervention is defined in cases of sequelae of septic hip, sir?
So, if there is subluxation or dislocation, it should be treated immediately. You cannot wait and watch.
Okay, sir.
If the head is completely absent, and if you have to do Elizarov hip reconstruction,
Yes.
now people feel that you should do it as close to maturity as possible, because if you do an osteotomy at age 5 or 6, it will remodel, and again you will have to do recurrent surgeries. Okay, so
in fact, I was going to ask you about that, because the child you did was about 5 or 6, and
so I still did. So I'm going to answer you that, John. So I've done both. I've done treated patients early and treated patients late, and there is a literature, to support early surgery and late surgery both. So if you are doing an early surgery at age of 5 or 6, you have to do overcorrection. If you do overcorrection and at the same time you fuse the trochanter, there will be no remodeling. So you will give stability to these children at a very early age. And John, if you would have, since you have a long-term follow-up yourself, what I've noticed, it's semblance of, femoral head forms where you have done the osteotomy in children where you have done osteotomy early. So I still do very early and lengthening.
So I agree that you should do it at that time, because you can't leave them like that. But you need to warn them that you may need to repeat the osteotomy.
Yes.
Because they do remodel.
If you overcorrect them and actually get them into 10-15 degree valgus or abduction deformity and do trochanteric epiphysiodesis at that time, then the chances that you will require a revision proximal femoral surgery will be less.
Yeah, I think, so maybe, but I think when you overcorrect them, then you have to be careful of the long-term effects on the knee as well. So, because there's a limit to how much you can parasite it.
At the hip and then give varus at the lower femur.
No, so but if you really look at the axes and actually measure them, it's never perfect. But yeah, you can't expect perfection in these cases. I mean, I think you get them somewhere near normal, they do a lot better. And you're right that they are they actually do quite well clinically.
So two things which Gifrao described in his original article on hip reconstruction, which we sometimes don't follow, and these two things are overcorrection to get 15 degree abduction deformity. That was one point. And the second point, he said also give extension. We always think of hip in one dimension, PBH, X-ray, AP. We never think of extension liver arm. The abduction liver arm is something which we have always been taught, but extension liver arm we have not been taught, which is actually more important for propulsion. So this also
I think so. Yeah, I agree. So, but whenever you're doing the Elizarov osteotomies, you actually put the limb in full adduction.
Yes.
And do it at the level where the hip, the femur comes under the ischium. So when you correct it to you're actually doing an overcorrection.
Yes.
Okay. Always doing an overcorrection.
Yes.
Sir,
Sorry?
I can't hear the question. Yeah.
Sir, why? Sorry, sir. Suppose we are doing surgery by Elizarov reconstruction, and we are also planning for lengthening of the limb, sir.
Yes.
And you said over lengthening should be done. Then how much over lengthening, sir?
So at the time, in a child, you cannot lengthen more than 4 to 5 centimeters. In that child, we had 3.5 centimeter shortening, but we knew that as he grows, there'll be more shortening. So what I did in that child is, we did 3.5 centimeter to correct the limb length discrepancy, but additional 1.5 centimeter as investment for future. So that was investment for future shortening which would occur, because 5 centimeter lengthening, is permissible in a child.
Yeah,
so 3.5 was done for the present and 1.5 was done for the future. But you can't
also depends on the age of the child. So when you're doing them older, 13, 14, then you do not need to over lengthen. But at 5, you certainly would expect some further discussion.
Sir, if a child present with ankylosed hip as a sequelae of septic arthritis.
So ankylosed hip can be in 2 positions. If there is ankylosis in sound position, you just leave it alone, because it's a painless hip and you don't want to do anything. If it's ankylosis in unsound position, then you will have to do an osteotomy to get it into a sound position. If it's a fibrous ankylosis and a painful ankylosis, you have two choices. Either you can convert into girdle stone or you can convert into a bony ankylosis. And that will depend on what does the child want or what do the parents want.
Sir, can we classify ankylosed hip according to choice or any Unka?
So choice classification and Dr. Johri's classification, they have not had ankylosis. I'll tell you the reason why is it so. In sequelae of septic arthritis of the hip, most of the time you don't see ankylosis. You see in tuberculous arthritis, you see ankylosis, either fibrous or bony ankylosis. And why they have not included? Because these both studies were based on, grouping together a certain number of cases. Dr. Johri had 67 cases and Choi had a large number of cases, which they classified into certain groups. And probably they did not have a case which falls into the ankylosis category. That's why none of them have included ankylosis as a group, neither Dr. Johri or Dr. Choi. Because probably septic arthritis, which is bacterial, does not result in ankylosis.
Yeah, in fact, I think neonatal septic arthritis almost never results in an arthrodese. I think you get them in other things like post-traumatic infections and sort of tuberculosis maybe, but you never get it in neonatal septic arthritis. I haven't seen one in all these years.
Right.
Sir, I have one more question. So there is a test that is called a Desault's test for the fracture of proximal femurs. The movement arc got reduced. So that test can be applicable in these cases, sir.
So
what is Desault's test? Can you explain to us what that test is? Then we can.
If I have to appear for my MS again, I will.
I searched about that. I don't know how to do it properly. I have heard about it.
Desault sign is actually a full range of motion of hip.
They say arc of the movement is reduced.
Pathological condition. Yeah, that is Desault sign. Positive.
Yeah. So send me details of the test. I will, look into it, and then I will also answer you if that is applicable to post-septic hip.
Yeah. Yes, sir.
Okay. So Narayan, yeah.
Yes, sir. Sir, from one question, sir. Sir, it is said that intervention should be done within 6 to 10 hours in case of the septic arthritis. So should we wait for the antibiotic to come in the action or to go directly for the surgical intervention?
So there are two problems in septic arthritis of the hip. One is that there is tamponade. There is a lot of pressure. And the second issue is there is infection, which needs antibiotics. Now it's very important that we get a bacteriological diagnosis to know what is the organism and what is the antibiotic sensitivity. And for that reason, aspiration or decompression should always precede starting of antibiotic.
Yes.
So many times what people do, moment they have a septic arthritis of the hip, they will investigate, they will do an ultrasound or MRI. And once the diagnosis is confirmed, first thing they will do is start with broad spectrum antibiotic. And if the child does not respond, then, aspiration or surgery is done. I think what should be done is, as the child gets admitted with suspected septic arthritis of the hip, what we do is first put an IV line. When we put an IV line, we do collect blood for investigation, which is CBC, ESR, most important C-reactive proteins, and we also send it for blood culture. Having done that, the patient will undergo an ultrasound or MRI if the child has not undergone that. If it's possible, we at least collect a sample, by aspiration under ultrasound, so that sample can be sent for culture and antibiotic sensitivity. Before starting the antibiotic, we take the patient into the OT for aspiration and decompression, and the antibiotic is given after you have collected the sample. Okay, so anesthetist is told that don't give a pre-incision antibiotic. The antibiotic is started after you've obtained a sample for culture, because otherwise your the result of retrieving an organism and antibiotic sensitivity will go down. So that's the order in which ideally you should work. But most of the time, by the time patient comes to you, either the pediatrician or other primary doctor has already given not one or two but multiple broad spectrum antibiotics, and then we have no choice. We have to deal with that situation and do whatever is best available. Having said that, at least in metro cities now we have a lot of tests available, like gene expert tests available, where we can identify organisms and get antibiotic sensitivity, even if antibiotic has been given previously, because it does not depend on the growth of the bacteria in a culture media. It depends on presence of antigen. And from the bacterial antigen, they will tell us whether what antibiotic will act. And sort of availability of this gene expert tests and RT-PCRs for organisms have given rise to rapid diagnosis of what is the organism and what is the antibiotic sensitivity test. So what is what is new in management of septic arthritis is not orthopedic. It is microbiological and pharmacological. New antibiotic regimes have come where we don't give antibiotics for 6 weeks now. We give short-term antibiotic courses. Sometimes it is for 2 weeks or 4 weeks. You give IV antibiotics till the time CRP touches baseline. Okay, you don't give compulsorily 6 weeks antibiotics. So what is new in treatment of septic arthritis is not orthopedic. We are doing same thing which John's father was doing and maybe his grandfather was doing. Nothing else has changed.
Grandfather was an orthopedic surgeon. wasn't even a doctor. So I hope he was not doing it.
Yeah, those times. I'm just saying. In last 100 years, the principles of surgical management have not changed. But what has changed are investigations and the antibiotic treatment.
So I think ultrasound guided aspiration is probably the first thing you should do when they come early to you. Okay.
Right.
Problem is when they come late, then it loses some of its advantages. I think the real dilemma is when they come kind of halfway through, when they've had some antibiotics, they've partially responded, there are already some sequelae that you can tell on the hip, and then it's a dilemma whether you still go in and drain or whether you continue with the antibiotics and suppress the disease. What is your school of thought in this?
One more sort of point I would like to add, which is again a controversy, is what should you send for culture? So if you send an aspirated pus for culture, it has least chance of isolating an organism. You should send the tissue. So when you are debriding, you should send the tissue. And if you send the tissue, that has the best chance for isolating an organism and growing them. So again, ultrasound guided pus, though we send regularly, it has its own limitations. And whenever you're operating and doing an arthroplasty, we should always send a tissue for culture.
Yeah, if you're operating, that's a different issue, but you don't have to operate on every child with septic arthritis, because if you catch them within 24 to 48 hours, I think.
Yeah. So there is a role for aspiration and lavage, but just aspiration will not do. You should put the needles and give a wash.
Wash it out. Okay.
Yeah. But
Sir.
Yes.
What is the Harman reconstruction and how it is different from modified one, sir? And when it is indicated?
So again, these are all sorts of trochanteric arthroplasties where you make a femoral head from the trochanter. So all these procedures have only two importance. One is in the history and second is your MS or DNB exam when you're writing a theory paper. Practically, I don't think anyone does these procedures nowadays because they don't have predictability of result. Okay, and there are very few indications for doing a Harman procedure or a modified one. And I really don't think that in current world, these procedures have a valid utility.
So there's the colon arthroplasty where you actually do an osteotomy and turn the trochanter into the head, into like head into the hip. So I think very rarely are these done anymore. I think these are
because they are not needed, and there are good alternative, more predictable procedures available now when the head is up.
Historical interest than anything else.
Yeah.
Okay, sir.
But you need to know about it, because they could ask you these in the exams, because
and they can ask you also on the webinar.
Yeah. So because they some of the examiners would be old school. Okay, so that's something you have to be aware of.
Yes, sir.
Yes, sir.
I just want to ask one question, sir, that most of the postgraduate in medical college used to attend neonatal ward or NICU. So they are the first visitor for the child. So what all precaution we should take that there should not miss a case of early neonatal sepsis?
So, firstly, to establish if you are in a teaching hospital, you must take a small class for your neonatology colleagues, so that the pediatric residents are the ones who are going to pick this up early. And a very simple test is to pick up the baby. When you pick up a neonate, they will flex the hips. And if when you pick up the child, if one of the hip is excessively flexed and child is not moving that hip, immediately the suspicion of septic arthritis, should come. And the first investigation they should do is an ultrasound as soon as possible. Now there are conditions where ultrasound is negative, but you have a strong suspicion, no, this looks like septic arthritis of the hip because child is toxic, there is fever, there is restriction of movement, there is pseudoparalysis. In that case, there is nothing wrong in doing an MR to confirm the diagnosis. So MRI today is the investigation if available. If it's available, it is affordable because, most of the time if it's required, you can get it down, the price down, or do it also free in most of the centers. So MRI is a investigation of choice and not just an ultrasound. Ultrasound is initial investigation. But if you're going to operate the child, always do an MRI because that allows you to differentiate between plain septic arthritis and septic arthritis with an associated osteomyelitis. So if you treat septic arthritis and miss the osteomyelitis, again, it's a problem. Okay. So clinically, again, coming back to your question, our pediatric colleagues must be told about this simple test of lifting the child, and every child where there is pseudoparalysis of limb must be investigated for septic arthritis without delay.
Yeah, I think that's the key, because what happens is a lot of these people are getting antibiotics for whatever problem they have. Any fever, any chest thing, they're getting antibiotics. And in the meantime, they have this septic arthritis of the hip that gets completely missed out. So in some places, the moment they get contacted, the pediatric surgeon will go in and put needles into the hips blindly just to make sure there's no pus in them. Okay? Yes. Even without ultrasonic control, they put in needles in these neonates to just check if there's a septic arthritis. Do you do that, Taral?
No. Because portable ultrasounds are available.
And now it is, but at one time this was a very common thing in the neonatal units where they would just go and put in a needle to make that diagnosis, because otherwise, because the child can't tell you that I'm hurting here or there, or with all that needles strapped up there in the NICU, they have multiple IV lines going in different places, and you're never quite sure. So they used to do that just to tell if there was, and they were expert enough to do it blindly. But I think in our situation, I would rather do it with ultrasound. Yeah.
And so another thing, sir, you have mentioned about culture that we should take tissue and send it. I just want to compare it with open fracture or any fracture, infected fracture, where sir used to tell that we should take culture from 3 different planes, 6 samples. So for this one, sir, for septic arthritis, how many samples we should send?
You don't get such profuse material in septic arthritis. You get very little tissue. So there is no question of dividing into 6 or up to.
Yeah,
so whatever you get, you can.
So you send two separate things. One is of what if there's frank pus, you send that, but always send tissue as well. Okay.
But nowadays, at least in bigger hospital, the children hospital where I'm working and at Hinduja as well, now we have gene experts available, and we are really lucky because with very little sample, you get sometimes a drop of fluid. They are able to tell us if there is a sepsis and what is the organism and what is the antibiotic sensitivity. So I think that has helped.
And the other side of it is once you drain it, they actually do well.
Yes.
I mean, you give them some broad spectrum antibiotics, and it's the drainage that's important because then it takes off the tamponade and the chances. So the hip dislocating is another problem that you find in little babies. Yeah.
So after you drain, it's very important to protect that hip. And polyc harness is not a very good solution because these children have multi-directional instability, and in polyc harness the hip will dislocate anteriorly. So either you brace them or you apply spica. If the two, even for a short time. It's important to stabilize these hips, immobilize them. Very important.
It's one common problem what we come across. Usually, the patient what receives is about 2 to 3 weeks delay of that neonatal sepsis, neonatal septic arthritis. So, in that case, what choices we have, sir?
So it depends on what the child presents with. If the child has come to you after 2 to 3 weeks but still has fever, high CRP, it means there is infection still present. And I would still treat it with debridement, and whatever is, if the head is present, you put it back. If it's dislocated, put it back. If part of it is destroyed, you just debride it. But you will still go down to save the rest of the hip. And you don't want the infection to spread. However, if you get a sequelae which is now quiet, where CRP is normal, the child has been given antibiotic, has not been treated well, then in that case, I will try to go slow. I will not be very aggressive.
Exactly. So it's a
yes, John.
Yeah. We were talking about these late presentations where sometimes there's some background sound coming from somewhere. Anyways, there's some issues about surgery and whether you're actually going to give any further benefit at that stage. When is that stage when you decide, okay, it's better to just give this child antibiotics because it's already a stage where I will not get a completely normal hip, or you would go in and drain anytime there's any little bit of collection?
So if there is a delayed presentation, that's what I was answering, that it would depend on acuity of infection. Exactly. So if the CRP is high, child is running fever intermittently, counts are high, then you have no choice, you have to go down. But if the hip is quiet, child doesn't have much pain, you just accept whatever is there. I want to confirm again in these patients that hip is not dislocated. If hip is dislocated but present, you would still go down and put it back. Sure. But if child has, semi, healed infection, where there is no infection now, but there is hip in reparative process, then I'm not going to go down and damage it more. Then you better give it a chance, give it a good positioning in a positioning device, and then sometimes after 2 to 3 weeks or 4 weeks, you do an MR to check what is happening to the femoral head.
And putting a child in spica, especially it's a 3-week, 4-week-old child, is not a. So I think I would look at the hip at surgery, and if it's stable, only then do it. Otherwise, I'd give them an abduction brace or something like that.
Yes, yeah. Same thing. I have the same protocol. Most of the time, we end up giving a brace. Very rarely, you have to give a spica. Very rarely.
Yeah, if it's already dislocated and you're putting it back, then definitely you need a spica.
Yes.
And so usually we have a high index of suspicion for septic arthritis, and we sometimes misdiagnose that transient synovitis also as septic arthritis. So is it wise to do an arthrotomy on a transient synovitis?
Why would you mistake the two? I think you shouldn't mistake the two.
So first of all, clinical picture is different. Transient synovitis doesn't have fever. The hip joint is quiet. The range of movement is painful only terminally. It's on and off, and moment you give ibuprofen, the pain will go. Septic arthritis, will follow Cocker's criteria or modified Cocker's criteria. Will have leukocytosis, pain, the child has difficulty in walking, there is restriction of range of movement, CRP is high. And most important, if you do an ultrasound, you can differentiate between transudate and exudate. If in doubt, you can also do, MRI in these patients to check before doing arthrotomy. Arthrotomy for transient synovitis with a suspicion of septic arthritis, not justified.
Yeah, so I think you're more likely to mistake transient synovitis with Perthes or something like that than through septic arthritis. Yeah, because some of the Perthes present very similarly initially, and so that's something you need to watch out for. But septic arthritis will be a much more acute sort of presentation with much more restriction of motion, etc. Fever, child will be toxic. There are lots of things that will be there.
And so when we are doing surgery for sequelae of septic arthritis, usually when it is silent infection, then at that time, what is the usual criteria to start antibiotic, or for how many weeks we should give it? Because there was previous infection.
So when you are dealing with a sequelae of septic arthritis where infection is not present, I just give 1 dose of antibiotic or 2 doses.
You give prophylactic antibiotic, that is
like a normal surgery, routine surgery.
And so you have mentioned about that Coxa Vara surgeries and also. So I have just one question about the terminology, sir. That acetabuloplasty, what we are saying is for all the surgery, all the reconstruction surgery which is done for acetabulum, like that osteotomy, not for that.
Acetabuloplasty is when you're changing the shape of the acetabulum. Okay.
So for conclusion,
yeah. So when you get the roof down, which is a pliable roof, you just cut above the roof and get the roof down. These are acetabuloplastics. So Degas acetabuloplasty or Pemberton surgery, these are all acetabuloplastics. Salters, then Sutherland surgery and triple innominate osteotomy are redirectional osteotomy. So they are not called as acetabuloplastics because the entire acetabulum is rotated. And then you have shelf procedures and some other procedures which are salvage surgery. So the classification of acetabular procedures is very well known, and acetabuloplastics are just one section of the acetabular reconstructions.
You're actually changing the shape of the acetabulum. Okay, that's the.
And so for you have mentioned about the 2 classification, although there are so many classification for the sequelae of septic arthritis. So for the DNVs, what is your advice? Which classification they should remember for the examination, for the viva?
Yeah, what we have mentioned.
These two basically. The only problem with, I think, is jury's one published anywhere yet?
Yeah, in IGO, Indian Journal.
Okay, IGO, he's finally published it because he hadn't published it for a long time. So,
and it is known,
it's well known, but
well known, well presented.
Yeah, it's an excellent.
They would be expected. Only
it's
thing
a very
is
practical classification.
Very, very difficult to remember because so these two classifications also reflect personalities of the people who coined those classifications. So Dr. Bowen,
I will pass that on to Ashok.
I've told him that.
I know, I'm just joking.
But a very big contribution of Dr. Jory's classification is that he's the one who looked at the stability, the 2 types, the stable hips and unstable hips. He said that unstable hips had better function.
Yeah, very often.
And stable hips, did not have a good function.
So that is the other sort of dilemma sometimes is when you have a dislocated hip, which is functional, do you then bring it back into the joint when they come late and then end up with a stiff hip in the joint?
So
it's that's why such surgery should be left to people who are experts, because as compared to surgery for a dislocated DDH versus a dislocated septic hip, which comes as a sequelae, the septic hip dislocation is much more complicated surgery.
Yeah.
And till the time you are actually reducing on table, you don't know whether you're going to do a varus osteotomy or valgus osteotomy. Sometimes if the head is, like vertical oblong, and you need to get it, horizontal, you may have to do a valgus osteotomy. So, so it should be left to an experienced pediatric orthopedic surgeon or an experienced hip surgeon to do such reconstructions.
True, absolutely. And I think, and the other thing is, you have to explain to the parents that they may end up with more stiffness than they had before, because earlier they are able to squat everything very happily.
Yeah.
And after this, they may not be able to squat properly sometimes.
Right.
So,
okay, I think we should let Taral go, poor chaps.
yes.
Tuesday evening is...
Just one question about that arthrogram. How often you used to do arthrogram before doing reconstruction procedures?
Many times, and it always gives you much more information, and it's something which I really love doing for a subluxated hip or a coxavara, because it gives you a lot more information, and not just before doing surgery. Sometimes we do intra-op arthrograms also.
So at one time for Perthes, pre-op arthrograms used to be a standard procedure, standard investigation. And you would put it in different positions to see which position. Now with MRI, you don't need that as much. But it used to be useful to actually look at the coverage, the size of the head, and also in which position it was best contained.
So even with MRI, I do it because MRI is not dynamic investigation.
Exactly.
So arthrogram is dynamic.
Yeah, so it's very useful to do pre-op to actually look at in Perthes the head is best position. And for hinged abduction and things like that, it gives you a very good idea of that.
Thank you so much, sir. It is very informative, and I think most of us learn almost have a basic idea about the sequelae now. Thank you so much.
Okay. Thank you, John and Janki, J&J, for inviting me.
Thank you so much.
And also Ashok and Neeraj for hosting this. Very
you can't put them on a acronym, huh? Ashok and Neeraj. Okay.
Thank you so much, sir.
Okay, thanks very much. Thanks, Taral. And I think that brings us to the end of this particular CME program. And again, till next week. Bye. Okay, bye, Taral. Thanks a lot. Okay.
Good night, sir.